Good afternoon, everyone. Would like to welcome you to the webinar. Thanks for joining us. We've got a few people popping in here, so we'll take it slow to start with. My name is Robert Love with Devero, and we're excited to be here. This is the first of our series of webinars designed to educate the industry in these changing times. And what we're doing is collaborating with our partners to bring information at no charge to the industry. And we've got a great series lined up. Our first here, we're pleased to present with SHP, one of our great partners. We have many mutual customers, and we're talking about value-based purchasing trends and reporting. While we're waiting for people to join us, I'd like to just give a quick plug for the upcoming webinars we have as well, and everyone will get links to these in the follow-up email. Coming up next month, we'll be talking about the new home health conditions of participation, and we've already got quite a number of registrants for that webinar. Home care marketing has changed quite a bit over the last couple of years, and we're bringing in our partner Playmaker to talk about marketing strategies that work for 2017, and that's coming up in April. And then the fourth in this series is improving clinical coordination with secure messaging. Using secure messaging, secure texting, and other collaboration tools, what that looks like and what's available to you out there, and how they help improve clinical coordination. And that's happening in May. So again, you'll have links to all of these in the follow-up emails that we send out. We are recording this webinar. I just want to let everybody know. We will give you the link to this in case anyone happens to have audio trouble or can't get in for whatever reason. But I wanted to just give you a quick tutorial on the GoToWebinar pane. A lot of people ask, well, how can I hide it? It's impeding my view of the webinar, and it's just that little orange arrow that points to the right. You can click that. It will close the pane, and you can open it with the other arrow that shows up there. If you're having audio, I'd encourage you to, having audio trouble rather, I'd encourage you to hang up and call in again. You can get the audio information by clicking that plus button next to the audio text right there, and that'll give you the opportunity to dial in with a phone or listen through your computer. We will be answering questions toward the end of the webinar, and that's what the questions pane is for. You can submit your question really at any time, and Chris and Zeb will go through those at the end of the webinar. And of course, we've got the handouts at the bottom of the pane. I did send those out just a little while ago in email. If you didn't get those, you can download those now. So before we begin, I wanted to do a quick poll just to see who's on the line. And what I want to do is ask you what state you're in. So if you wouldn't mind just answering quickly so we can see who's on the call. Now, I apologize for not giving each state its own answer line, but I only get 5 potential answers in these polls, so I had to lump a few states together based on rough geographic region. But I'll give everybody maybe like 20 more states to 20 more seconds to answer the poll. And 5, 4, 3, 2, 1. Here we go. I'm going to close it. And let's see if I can share it. It looks like the vast majority of attendees are in states other than current value-based purchasing states. So that's good to know. I'm going to go ahead and hide that now. And what I'd like to do is invite in Zeb and Chris from SHP to present the webinar. I'd like to thank everyone for joining us today, and Zeb and Chris, I'll let you take over.
All right, thanks a lot, Robert. This is Zeb Clayton, VP Client Services over here at SHP, and I'm joined by Chris Attaya, our VP of Business Intelligence. and we're really happy to be here today partnering with Devero to present this webinar. It's a topic that we've presented on several times in the past. It's obviously a hot topic in the home health care industry, and it's a relatively complex topic. So it's certainly, even if you've been to webinars on it before, I think every time we go through it, we find some new wrinkle or some change, some update that's happened. So it certainly is beneficial to go through and kind of talk through the home health value-based purchasing program, some of the foundations of it, how it's structured, and then also some trends we're seeing, and also how that, if you're utilizing SHP, some of the reporting that you have available in our system as we wrap up at the end. Just a quick review. We're going to be going through these different components. We're going to be describing the total performance score and the linear exchange function and how that impacts payment. We're also going to be giving some outcomes data from our SHP national database, which includes around 4,500 agencies, and also trends of VBP measures and how you can decide which measures to focus on. So first of all, we're going to go through some of the components of home health VBP and some of the lessons that have been learned from hospital VBP programs. Since they kind of got their feet wet in this before home health, it's kind of nice to not be the first ones to go through this, so we can learn from what they went through and how that progressed. Now, first of all, we just want to touch on this. This is not news to anybody on the webinar, I'm sure, but the pilot here started with 9 geographically defined groupings of 5 or 6 states based on geographic sample size and patient characteristics, and you can see them shown here on the United States map. They're Massachusetts, Maryland, North Carolina, Florida, Washington, Arizona, Iowa, Nebraska, and Tennessee. And from what I saw on the poll, it looked like Florida had the biggest representation of VBP pilot states here in our webinar today. So let's just take a quick run through. We're not going to spend a ton of time on this, but we do want to go through some of the basic tenets or components of the 2016 final rule as it applies to home health VBP. It's a 5-year pilot, starting with the performance year of 2016, which obviously is already completed. We'll be talking about what a performance year is and how it impacts your VBP score. Also, there's a bonus or penalty up to 3% in the first year, and then it progresses to 5%, 6%, 7%, and 8% on a yearly basis. The baseline year of 2015 was used for calculating the median or achievement threshold and the mean of the top decile, also known as the benchmark. So we're going to be talking about those thresholds and benchmarks, what those mean, and how they will affect your payment under VBP. Baseline scores are state-specific and separated out by small and large agencies or cohorts. This is something new for home health. Everything, while I think the closest we've had is on Home Health Compare. We have state benchmarks, but all of your, really being looked at in a silo as a state and being ranked against other performers within that state is a relatively new thing. So it's a bit of a learning experience for everybody. There are 21 OASIS claims and HH-CAHPS measures, along with 3 new measures that we'll be walking through. There are up to 10 points for achievement and improvement for each measure, and you get the higher of those 2 scores. And again, we'll show how that's calculated. There's a total performance score for each CCN, and that's used to calculate the linear exchange function, which we will also define for you.
And I'll say, Zeb, this was the 2016 final rule, and so based on that, that's what everybody was expecting to see this year. But in fact, we learned some new things, which we'll describe in a minute, of what they said in the 2017 rule that changed a couple of those factors. So we'll get to that slide too.
Absolutely. Thanks, Chris. So here we're taking a look at the baseline of performance periods. And as you can see here, in 2018 is where you have a 3% payment adjustment, 2019 of 5%, 2020 a 6%, 21 a 7%, and 22 an 8% payment adjustment there over that 5-year span. So the first year that those payment adjustments would be showing up would be 2018.
And you can see from that first column, 2015 is intended to be the base year for the entire period. I think you said that, but I think graphically that's what you see here.
Yeah, good to remember that the baseline year is already set, completed, and set in stone. Is not going to change throughout that entire payment adjustment period. And you'll see how that will impact you as we go through this. Now, as Chris mentioned, with the November 3rd, 2016 release of the 2017 final rule, there were some changes, some small and some that had a fairly big impact. I think probably one of the biggest changes was dropping 4 of those 21 measures. And so those, I think there was a lot of angst over in VBP states, particularly in pilot states, over how those measures were going to be defined. We didn't have a lot of detail. We were already in these performance periods, and no news was forthcoming. And thankfully, I think everyone breathed a sigh of relief when ultimately those measures were dropped, and we didn't have to worry about how those were going to be impacting your overall performance. Also, there was changes to the performance benchmarks and thresholds calculations without regard to size, so the large and small cohort element being removed. And also, the size of the small cohort was limited to 8 CCNs in a state with a linear exchange function. So, Chris, if I understand that correctly, states with less than 8 CCNs in the small cohort would not have a small cohort.
That's correct. Yeah.
Also, the review request time period was reduced from 30 days to 15 days, so kind of shorten that time window in which you can ask for a review request. Also, the new measures were to be entered within 15 days after the end of the quarter, and we'll give you a look at how those new measures work if you haven't already seen those. Also, the employee flu measure was changed to be reported annually instead of quarterly, and that started in April 2015. And so that was a change from previous. I do see a question there. I just saw, Valerie, you said, what is a CCN? Basically a Medicare provider, essentially.
Yes, it stands for CMS certification number, and it's essentially your provider number.
Yeah, so and that's a 6-digit number. If you're trying to identify that, it should be 6 digits. And then last of all, there was an appeals process that was set up that includes a recalculation and reconsideration process as well, so that was defined. Now, we want to take a look here at these measures by NQF domain. So what we're talking about there is each of those remaining measures in the VBP calculation was assigned to a domain. And some of those had up to 5 measures in them. Some of them were a single measure. As you can see here, those are listed down at the bottom. There are 6 different domains. They're patient and caregiver-centered experience, basically the 4 CAPS measures. 4 of the CAPS measures, communicate or clinical quality of care, communication and care coordination, population health, efficiency and cost reduction, and then last of all, safety for the final CAPS measure. Mabel, I see your question there. Is the penalty of 3 to 8% also able to be a bonus as well? Yes, and we will be showing in a little bit how that distribution will occur. It could be either a penalty or a bonus, and will vary. It basically will be distributed among higher performing providers, and you'll get a little bit of a window into some examples of how that would happen in a little bit. So let's just talk about an overview here of measure point scoring, and then we'll show an example of how this works. So each measure is going to have points scored based on the higher of an achievement or an improvement score. So using the base year, which as we set out is 2015, 2 calculations are set. There's an achievement threshold, which is the median or the 50th percentile, basically dead center. And then the benchmark, which is the mean of the top decile, or to keep it a little simpler, around the 95th percentile, more or less. Now that base year, as we mentioned, the calendar year 2015 does not change. The performance years are going to be 2016 through 2020. And each measure needs 20 or more episodes to be included in the TPS, or the total performance score. The new measures that are entered manually into the CMS website, those are going to be scored based on self-reporting data only, which is essentially just, it's a pass or fail. Did you enter the data? It's not a quality measure. It has nothing to do with performance. It's just, did you do it? And if you reported, you get the points. So let's take a look here at a little more detail on achievement points by state. Now, these are awarded by comparing an individual provider or CCN or home health agency's rates during the performance period with all of the other home health agencies' rates from the baseline period. Now, you can rate better, equal to, or better than the benchmark, which, if you remember, a benchmark was that that median, that middle of the pack, or the middle of the pack
of the 95th.
I'm sorry, yep, 95th percentile, around the 95th percentile. Or you can rate less than, or if you rate less than the achievement threshold, you get 0 points. If you rate equal to or better than the achievement threshold and worse than the benchmark, you get somewhere in the range of 0 to 10 points for that measure. Now, let's take a look at this. We're going to look at improvement points, and then we're going to show you an example, a sample of exactly what that algorithm would look like for a provider, a sample provider. Improvement points is basically, if you think here, you're being compared to yourself. It's gauging your improvement over time and seeing, did you get better? This is basically comparing your performance during the performance period with your same rates from the baseline period in 2015. If you rate better than or equal to the benchmark, that 95th percentile, you get 10 points. If you rate worse than the base year rate, you get 0 points. If you rate equal to or better than the agency's base year rate and worse than the benchmark, you get between 0 and 10 points.
So if you're not better than the median, so you're getting no points for achievement, but you did improve over the base year, you can get some points. And I think that was the intention, to kind of help providers get something for making improvements in quality.
Exactly. So let's take a look here. This is a simple example. Then we're going to zoom in on this and look at it in a little more detail. So this is for the pneumococcal vaccine measure. As you can see here, we've got between 0 and 100 as our potential score. The threshold for this measure is at 47.4%. That's that median. And then the benchmark is at 87.5%. That's that 95th percentile. So let's see how this would be calculated here. If we look at this example, you can see the little house up at the top. That represents the score for this provider in the performance period, a 70.3% score for that pneumococcal vaccination measure. Now, as you look here, you can see we have a line for the achievement range and a line for the improvement range. So as you can see, we have a range between, for the for the state benchmark, 47.4 between 47.4 and 87.5. So their rank in there, they fell right in between 5 and 6 points, 5.640 points for the achievement score. Now, what is going to happen is you're also simultaneously going to calculate the improvement score. You can see that ranges between 21.1, which was in the base year, their score for that measure, and 87.5. And that's, again, that the top end, that 95th percentile. Since their score was so low in the base year, you can see that their ranking for the improvement score, where they ranked there, actually was higher than their achievement score. And so they have a score of 6.906%. I'm sorry, 6.906. Since they scored higher for the improvement range, then they're going to get the higher of those two scores, which was the 6.906. And so that base year is well passed, but for a provider that scored poorly on a measure, they're much more likely to get improvement points as long as they can maintain high performance in the performance years than they are achievement scores. For a provider that scored really well in the base year, they're going to be likely to get points in the achievement range because their performance in the base year was already really good. So this just kind of helps to see how that choice is made between where you get points, whether it's improvement or achievement. And remember, this is done on a measure-by-measure case, and you get points for each individual measure.
In the final rule, you can actually see the actual calculation that they're using to do each of these scores. So you can see specifically the improvement or the achievement score. So that may be something, if you haven't seen it yet, you may want to take a look at that.
Now, a question was put in about which measures will be self-reported, and just look at this. Your wish is our command. We have a slide on it. These are the exact measures that will be self-reported. Those of you that are in BBP states, this is old hat because you've already had to submit this data. This happened in Q3 2016. Or for Q3 2016, and I would imagine for Q4, it would have already been submitted as well.
In January,
yeah,
right?
So in January, providers in VBP states will have already reported 2 quarters worth of data. And so the 3 measures are influenza vaccine coverage for home health care personnel, the herpes zoster or shingles vaccination, has the patient ever received the shingles vaccination, and then advanced care plan. Now, this is almost like we're setting these up. The question came in, how do you report self-measures? Well, we will go on to our next slide here. There's actually a template that is provided by CMS. This is right here is basically based on an Excel spreadsheet. It's pretty straightforward. But this is just one of these examples. This is the shingles vaccine for patients measure. But this shows you basically there's a list of questions that get answered, and then that data is submitted through a web portal to CMS on a quarterly or an annual basis for the flu vaccine measure. So, one point we were wanting to make with this is just the fact that when you think 3 measures, it sounds pretty straightforward. And you start digging into it, there's actually a fair amount of data that needs to be gathered and at the patient level. So this is, they're in preparing for this. It's not something you want to just wait till the last minute to think about gathering it. If you are not in a VBP state, it does behoove you to start thinking about this and looking into what's involved, because there is a certain amount of effort involved in gathering it.
Dave Marshall was asking whether or not you had to administer these vaccines in the home. As long as they received them anywhere is when you would say yes, they were done, whether it's the flu for your employees or for the shingles. Just keep in mind that it's just about entering in the data. You don't have to say I was successful in getting more to be on the flu vaccination. It's really just about reporting the data at this point.
Well, I'm going to go ahead now and I'm going to hand over to Chris, and he's going to take us into a look at performance reporting.
Sure, thanks, Zeb. So on a quarterly basis, providers now are getting regular reporting. We're calling them interim performance reports. So that way you can see, well, how am I doing? As you're going through the year, you don't want to wait and have the whole year be over before you find out. So the first report was posted in July, and that included data for Q1 of 2016. Keep in mind that that report, though, is preliminary because there can be calculation requests. So what we find now is that there is actually 2 interim reports made available per quarter. The first one is the preliminary, and then the second one is the final, which will be posted to the secure portal after it's been completed. So they'll actually replace that with the final IPR. From a performance reporting perspective, the most important thing is going to be, well, how did we do for the year? And so the first annual total performance score report will be issued next summer. Actually, I should say now this summer, August 1st. And then again, you'll have 15 days to request a recalculation. And because they added a reconsideration element, you will have an additional 15 days if you need it to be reconsidered. The final report, though, will be issued no later than 30 days before the change taking place. So that would be essentially by December 1st. And they have also notified us that the the annual quality reports won't be made public, though, until calendar year 2019. So I think they want to make sure they've had a chance to take a look at this. So the IPR, I think Valerie was asking, that's Interim Provider Review Report, so that's what that stands for. So one of the things that I think we've been talking about is, this is kind of a new pilot that they're doing. And, CMS has done a lot of webinars and Q&As. It's been very helpful, but it hasn't always been all that clear. When they came up with the final rule, as Zeb had noted, those 4 measures that weren't defined well enough, when they took them out, that helped a lot. They're also using a Connect website as a way for agencies to dialogue among themselves, to share information about best practices, although I don't know if you're competing with somebody in your state, if you're necessarily willing to share all your best practices. It's very clear, CMMI has made clear that this was a pilot and this was new. So they were testing and learning and experimenting along the way, which is a little uneasy when in fact you think, my God, 3%, and then in some future, 8% of my revenue is going to be maybe at risk. I would want it to be more, less of a pilot and to have all those unanswered questions answered. This next slide shows that interim performance reports, that IPR, and when they're providing the data to share with them. And you can see, some are a little delayed because claims-based and HHCAHPS-based measures are a little bit further behind. So, you don't necessarily see exactly where you are along the way. One of the Q&As that I saw this fall, which was pretty important, if you were to look at the actual calculation in the final rule for how they determine achievement points, there was some corrections. They actually said, wait a second, oh, you're right. There are some opportunities because of that calculation where you could get some points if you were actually below the achievement threshold. Well, they've now fixed that. Now you can't. And there were also times where you didn't get the full 10 points when you hit the benchmark. And again, it's inherent in the way that calculation was created. So they did fix those things as a part of the Q&As and some of the updates. Again, some good learning along the way. If you are a provider that gets the IPR because you're in one of those 9 states, they are sharing with you, interestingly, where you might stand in terms of your ranking, your percentile ranking. But keep in mind, though, it is still on kind of like a wide scale. So if you got a ranking of 50, you might go, I'm only at 50. But frankly, you could be at the 75th percentile, which would be pretty good, but only show on the report as 50. So I think when we talk a little bit later on about some of the reports that we have, you might see some better detail there that would help you see specifically where you are. Finally, in this section, I just wanted to talk to you a little bit about the hospital value-based purchasing. Is what have we learned about what they've done. And I think the most important thing to hear is they've actually changed the scope of the measures and the domains. Remember how we were talking about those NQF domains? Well, they've actually changed that over the last 5 years since the inception of hospital value-based purchasing. They do it similar, though, to what we have, is you either have that bonus or penalty, so that 3% can either be as up to 3% as a bonus or 3% to a penalty. That gets netted against the withholds that will happen when it starts up next year in 2018. They do have unlike the home health proposal, the base year for hospitals do change every year. So that's I think a little bit of the confusion. I've heard people say, I thought it changed. Well, it does in the hospitals, but not in home care. And finally, with the hospice caps, they actually get some points for some consistency. So this is what it looks like. I just want to share it real quick. They have 4 domains that they're using, but see how the measures at the bottom have changed. They've actually added and subtracted measures. And at the top, the percent, the proration of how much they're going to use towards that weighting has also changed. As it stands right now, all of the measures in home the home care value-based purchasing are equally weighted, but with hospitals, they're not. So I think it kind of gives us a little bit of a sense of what might be coming. I just wanted to show you a quick graphic. You know, this was based on the actual adjustments under the hospital VBP. This is when they have a plus or minus a bonus penalty of 3%. And you can see it's like a bell curve. That's what you would expect. Most of the hospitals are in that period between negative 1% to positive 1%. But then there's a tail that goes up when, in fact, you can actually get more than the 3%. Just because of the way the calculation is done. And we'll share that a little bit when we look at some of the TPS scores now.
So I'm going to now take a few slides and talk about the calculations of the TPS and the LEF and how that impacts payment adjustments. We're going to look at some hypotheticals as far as how the distribution of that withhold could look. Before I get into that, I just want to address a couple quick questions that came up. Two people asked, if you don't live in a state with value-based purchasing, will the baseline numbers change? Will you be using a different year for the base year? And as I understand it, and Chris, you can chime in as well, that will not change. As new states are added, the base year would stay 2015 for everybody, I mean, as we understand it.
Yeah,
now, right?
So they haven't said what will happen with the expansion yet on VBP. So I think we're going to have to wait and see if there's any other kind of consideration there.
Thank you. And Jeffrey, I saw your question too. Is there an estimate when California would be included? We'd be very popular if we knew that, I think, but as of right now, there's no indication of which next states would be added to the pilot.
The only thing we can refer back to is when they were working with a pilot that became the basis of PPS. So for those of us who have been in the industry a long time, you know, they started a pilot in 1997 for looking at prospective payment. It was a 5-year pilot. But they learned pretty quickly things were working the way they wanted, so within 3 years, and effective in 2000, they actually started PPS for all agencies. So again, it's going to be a function of how well they think this program's working.
So let's go in now and take a look at this calculation and give you some examples of how this distribution works and how the TPS calculation works. Now, CMS is proposing that the TPS and payment adjustments would be calculated based on a CCN and therefore would be based only on services provided in the selected states. Just a little nuance to keep in mind as we go through this. There are, as we mentioned, 17 OASIS, HH caps, and claims-based measures that are going to be used in the TPS unless an agency doesn't have 20 or more episodes per measure. So it could be less than 17 if you have measures that have less than 20 episodes eligible. And that's going to account for 90% of your TPS score. The 3 new measures that we talked about, those are going to account for 10% of the TPS score. Now, if you don't meet the threshold to generate scores on 5 or more of the clinical quality of care, outcome and efficiency, and person and caregiver-centered experience measures, no payment adjustment will be made. So basically it's a
status quo.
Yeah. So you're just excluded from the either positive or negative effects of the VBP withhold. So here's an example of basically a VBP scoring by measure for a provider. So as you can see, going down the right-hand side, we have scores there for each of the 17 measures. And some of those you will see have 0 points down there for them. And in looking at this, remember, you have to have scores for at least 5 of them in order to get a TPS score. So in this case, you would have enough measures with scores to calculate a TPS score.
And if you think about it, if you got 0 points, that means you didn't hit that threshold or you didn't improve. So you didn't get any points for that measure.
Exactly. So now you saw we had 93 total points down there at the bottom. As you can see, we have that raw total points reflected right here, and then 17 applicable measures right here. We have total applicable measure points, and then at 54.706% with that weight of 90 that we mentioned. And so you're taking that 54.706, multiplying it by 0.9, and then coming over there with the applicable measures final weighted score, if you want to get fancy, your AMFWS, being at 49.235%, or keep saying percent,
Yep.
points.
So keep in mind, you have 17 scores that you could get up to 10 points. So that's a total of 170.
Right.
So when you divide the 93 by the 170, that's where you get the 54. I didn't know there was going to be math in this webinar.
I was
to
not told there would be math.
I did want to share that.
I think we just showed our age with
Yes.
the Chevy Chase reference there.
Yes.
We then have our new measures as well, which, as we mentioned, account for 10% of your score. Now, with these, in most cases, we're going to assume it's going to be the rare case that a provider does not submit those measures. So in most cases, you're going to be getting 10 points for those if you submit all 3 measures. And then if you look down here at the bottom, you see you have your 49 points plus 10 points with your final score of just over 59 points. Now, let's take a look at how those points are then going to translate into reimbursement and how that reimbursement is going to impact your score and how it's going to be distributed. Each agency's VBP incentive payment amount for a fiscal year is going to be dependent on 2 things: the range and distribution of agency total performance scores, and then your agency's base operating HRG payment amount. If you have very, very low revenue for the year, a small or a penalty or a bonus is going to have very little impact on you in the big picture, whereas an agency with a very large revenue amount for the year, it could have a very big positive or negative impact. The value-based incentive payment amount for each agency is going to be applied as an adjustment to the base operating HRG payment amount for each episode. So basically that is going to be it's going to be impacted right there. That adjustment is going to be based on what your bonus or your withhold is.
So if you had a 2% bonus starting in January of 2018, they will add that 2% to your baseline bill that you sent out to Medicare.
So let's take a look at our next acronym here, our linear exchange function, our LEF. Now, CMS is going to use that linear exchange function to determine the distribution of that pool, basically the available amount of value-based incentive payments that are going to get applied to agencies in these pilot states, based on each agency's total performance scores on those VBP measures. So this here, I believe this example was shared, Chris, in the 2016 final rule, correct?
Yeah. So it kind of shows the first 2 columns there, the TPS score at C1. Those are the different scores that an agency could have, and in the second column is the kind of aggregate home health Medicare payments that they received. And those are the only 2 variables that are in this equation. Everything else is just a calculation.
Absolutely. And as you can see, if you look at the final column, this is based on an example where there was an 8% penalty, basically, or pool withhold.
Yeah, that's right.
And so this is kind of if we were looking at the end of that pilot period as it stands right now, that would be the maximum payment adjustment or withhold.
That's correct.
So what we're going to do here, we're going to go through several slides here and just give you some hypotheticals as far as how this distribution could work. Now, using the revenues that we saw on the last slide, but adjusting it to a 3% withhold, so basically that first payment adjustment year, this shows 50 scores on basically on a bell curve distribution. As you can see there, the blue lines with that agency count, just a very normal distribution there. The black line that we show here is our LEF indicator. Now, what this demonstrates and what we want to really make sure is that this is, what we call a zero-sum game. Basically, there's everything that's withheld gets redistributed to the providers. This isn't about Medicare, getting to get a cut of the pie here, if you will. Whatever they're taking back, they're redistributing. The intent here is not to pay less; it's to pay more to higher performing providers. And so, as you can see here, those adjustments for lower performing providers, you have from a negative 2.4% up to a positive 2.7% for providers that scored 100 on their TPS. So that's one example of a very normal, somewhat boring distribution of scores. So let's get a little crazy with it and see what would happen if we change some of these distributions. So in this example here, this shows what happens if a large number of providers get a 50 on their TPS. So basically middle of the pack, right in the middle. You can see a big spike in agency count. We don't have the nice smooth bell curve like we had in that last example. And remember, this is still based on a 3% withhold. But what you see is because of that big spike in the middle, the few providers that did score 100 actually got more than 3%. Even though there was only a 3% withhold. So when there is a group, when there's a bunching in the middle, a high-performing agency could stand to do very well in that distribution. Now, that's not something you control. All you can control is your performance. But if that distribution happens to favor you by a grouping in the middle, you can do very well. Now, one other thing that we did here was we looked at an example of a pool of 50 providers, again, but where one provider has a very large revenue total of around $10 million. Now, what we do here is you can see the gray bars said if that $10 million provider scored a 20, the blue bars say if that $10 million provider scored a 50, and the orange bars if that $10 million provider scored an 80 on their TPS. So if they were a poor performing, very large provider, everybody else in the pool does well because they're taking a big hit on their revenue and they're not getting a lot of it back. If they score very well, there's a lot of skin in the game for them. They're going to do well, but everybody else is going to get a little less of that bonus pool because they're going to get a lot of it back, essentially. So it just shows that a large provider can have a big impact on that distribution.
So there are two things, right? There's the TPS score, and then there's the base year Medicare payment. So both of those are impacting it, and I think that's what that's showing.
Exactly. Now we're looking at another hypothetical here. This is our number 4 case. This shows what happens when agencies are clustered around a single score. In this case, as you can see, the agency count is right in the middle of a big bar. So basically, a large percentage of your agencies, 30 out of the 50, scored a 50. So basically, everyone did okay, or the bulk of providers did okay. In that case, as you would imagine, there's very little impact for everybody in the pool. Your max is 0.06%. So there's a very small positive adjustment and a very small negative adjustment. Now, taking that same concept here in our last example, what happens if you have that same bunching, but everybody does really well? You're in a state with a lot of top performers. Everybody scores around an 80. Well, the exact same thing happens. If everybody does well, everybody has almost no impact on their scores. A positive 0.4 and a negative 0.4%. So the takeaway being, if providers are bunched around a single score, where most of your providers are scoring in a certain range, there's going to be almost no impact overall for the providers in your state.
And we saw a little bit of that with the bell curve with the hospitals. If you recall, even though there was upwards of a 3% adjustment, most of them were between -1 and +1. So it's the same kind of idea. It's depending upon the distribution of those TPS scores.
Exactly. So I'm going to hand back over to Chris now, and he's going to be taking a look at some outcomes data from the SHP database and some trends over time, so you can help to focus, know which measures to focus on.
Okay, I see we got about 15 minutes left, Zeb, so I'm going to kind of make my way through this. There's a lot of numbers to look at here, but I think what I wanted to share, though, kind of back to your point, you have to know how everyone else in your cohort or within your state are doing, because if everybody's improving and you're not, you actually are going to have less of a score. Your ranking will be worse in that example. So what we wanted to do is look at a couple of different measures. This first one is an outcome measure for ambulation, and we looked at it within each individual quarter, and as you'll see, across the 9 states, everyone has been improving. So you can see from the first column to Q2 2016 in this example, although there's been some spikes up and down, everyone has improved. In the next example, when you look at process measures, this is one example of drug education. Again, everyone is improving. So you need to be improving equal, if not better, than everyone else in your state, or else you won't be in a more positive position. Interestingly here, you can see in a few states, the median is actually at 100%, so they're pretty much topped out in that example. The one area that everyone has had difficulty, at least as we look at our data, is with HHCAHPS, and this is one of the measures of HHCAHPS specific care issues. And you can kind of see here, actually only 5 of the states actually saw improvements across the different quarter periods that we're showing here. So that's something to be aware of. If you can find ways to take advantage of some of the process improvements or quality improvements that you can do here, you might be in a little bit better position to get the higher points, which actually will improve your overall TPS score. So that's something to think about. So when we talk about points, one of the things we are suggesting that agencies try to do in those 9 states is to look at those 17 measures and say, where is my opportunity to spend resources to actually try to improve my score so that I have the best chance to get the highest TPS that I can. So as you've shared, I think, Zeb, you've kind of talked about how the calculation works. Well, if you take what is in the kind of calculation for both achievement and improvement scores, and you actually put it into an Excel format, you can actually create something reasonably simply where you can kind of say, well, what will happen if I can change anything in that yellow box? So actually create a template that says if I have an opportunity to improve my score, how will that change either my achievement or my improvement points? So let's look at ambulation as one example. So let's say you, in your base year, you have a score of 73. That year's particular threshold, that median is 69.1, the benchmark is 92.1. Behind the scenes, the calculation shows you would get the higher of 2.4 points, 2.417, if your agency has a score of 74 in that first year performance. Okay, so you improved, you get improvement points, you're above the threshold, that's the calculation. And that may be realistic because this was a star rating, so you actually made improvements that you were expecting to get in 2016. But what happens if I took and worked with my lowest performers? So I kind of looked at my reporting and I saw which clinicians weren't scoring well, and I got them all to at least get to that median range in my organization, and I could score 78. If that were possible, you would score 3.983 points because your achievement points would go up. And then finally, if I took a lot of investment and hired some people to come in and help train us to improve on this particular measure, and I could get to a score of 85, you can see you can get upwards of 6.72 points. So the point is, you have to decide which measures I'm going to focus on. And so by having the ability to look at some of this internally, I think becomes an important way to think about improving your overall scores. So some of the considerations you might be making as you're thinking about improving your overall TPS, what clinicians do I need to work on who can help me improve my overall scoring? What are the easier measures to change? Clearly process measures are easier than outcomes, which is easier than HHCAPs. Do I have some best practices already in my agency? When I look at it by team, do I see this team does well, this one doesn't? Hey, what can I learn from the best practices of that good team? So drilling down by branch, by clinician will help to evaluate that. But we always have to ask that question. The CFO in me always says, but at what cost? What's my return on my investment? If I'm a $1 million Medicare revenue agency and I've got $30,000 at risk, do I want to spend more than $30,000 to kind of improve my scores? But then, as you saw with some of the graphs that we showed you, but if you don't improve your score equal to what everyone else is doing, then the possibility of you going into a lower bonus or even to a negative penalty exists. So we just wanted to share that as kind of things to think about. And Zeb, I'll turn it back to you just to kind of give a quick view of one of the reports that we're sharing now.
Sure. We want to take just a moment to kind of give you a kind of a practical look at how you could do, what Chris was just talking about, looking at your scores, evaluating them, and seeing how you could track your performance over time and get a preview of whether you're in a VBP state or not, get a preview of what your scores might be. This is the real-time VBP Total Performance Score report that we have available in SHP. And to just kind of walk through this with you, I know we just have a few minutes left, but we just kind of want to give you a look at what this does. We, of course, have the VBP measures over there on the left-hand side, which shows outcomes, process measures, HHCAPs, and helps you to see which type of measure it is. And I see, Mabel, I saw your question, if you're on SHP already, are you able to get this report? Yes, it's under your financial reports section of your SHP reports menu. If you don't see it, it may be that you don't have the financial role on your login, but if you do, you should have access to it, and if you can't see it, your customer manager can assist you with getting access to it. You'll notice there that we're doing a little sparkline trend there that shows your performance over the last 12 months with high and low points. You can see how you're trending over time. And then you also have your current period score and a dynamic drill down to the patient detail behind that score. So you can actually click on that score, drill down, and see which outcomes, process measures, or HHCAP scores contributed at the patient level to that score on the report. We also have there from the base year the threshold and median for reference there. And then you'll also note there we have your 2015 baseline, so you can see compared. And then you've got the green dot there to show how you scored versus that threshold and benchmark. So you'll see where you did positively over the threshold or benchmark. We're then going to calculate your points, achievement and improvement, and then obviously you get the higher of the two. So that's what those three columns are going to show you there. And down at the bottom, the same calculation that we showed before. You're going to be able to see your points plus the. We're going to assume that you submitted the 3 new measures and give you those 10 points, and then give you your total performance score down at the bottom. And then once we calculate it, we're going to rank you there against your state. And we're going to show you the end. We're going to show you how many providers are in the pool and what your percentile ranking was against those providers. And as Chris mentioned earlier, when you're looking at your preview reports, if you're in a VBP state right now, you get a less granular ranking. It's just going to give you a more general bucket. On your SHP report, you're actually going to get a specific percent ranking that's going to tell you, if let's say you're at the 74th percentile, you might be right on the edge of moving up into the next bucket. You'll be able to see that here.
And one of the things about this that's nice is we will actually do this calculation for all states, not just the VBP states. So as you show as in the example, this could be California. So you could, because we're going to actually calculate using the CMS data what the threshold and benchmark are based on our calculation from that year against your CMS baseline. So you can kind of get a sense, you know, if we were to have it, am my percentile rank equal, higher, lower than the rest of the states? So pretty helpful.
Absolutely, and it's you know, definitely important to start preparing now. Even if you're not in one of those pilot states, it could be just around the corner.
And Ward asks, is the percentile ranking on the VBP report based on SHP data or CMS data? It is on SHP data, because we don't know necessarily, especially real time, because this is outcome measure data right to the current period, the current day. So we can only do it on our database. But I think it gives you a pretty good reference. So
Yeah.
if you're an SHP customer, you'll see that we have usually a pretty good penetration in each of those states.
Yeah, and what we've found so far since we're now well into this pilot for pilot states, we found that those scores that are being calculated against the SHP database tend to be very accurate when compared to what is being shown on the preview reports and the final scores. And some of that is just the size of the benchmark. We have a very good representation in most of these states.
Yep.
So I know that was a lot of information to absorb. I think we've answered most of our questions as we've gone through. But if you do have any remaining questions, please feel free to type them in. Jared, I see a question here. You said, has anything been said for the time lag between achievement points being determined and a change in cash flows?
I'm not sure I understand, Jared, exactly where you're going, but clearly a lot of providers are asking us, if I right now have a TPS score of 53, am I going to be getting a bonus or a penalty? And it's pretty hard to tell right now because you have to conclude the full year. Typically, if you're over the 50th percentile, you should and likely will be in a bonus situation. If you're below, but how much of that is going to be truly based on the final distribution of all the TPS scores in your state?
Well, Chris, Zeb, that was excellent. I think we're right up against the deadline here. Was there one more question you wanted to answer?
I just real quick, and I think you're going to note this. David had asked we'll be able to send this out for reference to our admin teams, and I believe Rob, you're going to give some information on how they can access the recorded webinar.
Absolutely. That was my two most popular questions. I was being messaged here. Number one, are we recording this? Because I think that folks wanted to show it to the rest of the folks in their agency, and the answer is yes. And so you will be receiving an email information with the webinar recording and the handouts, information about SHP, information about Devero. For the Devero customers on the line, I just wanted to mention I got a question about the self-reported measures, and there is a form in Devero that allows you to track the advanced care planning and the shingles vaccine. So contact support if you wanted more information on that if you're not already in one of the states that have rolled this out. So we do have our next series coming up here as well with the home health conditions of participation coming up in March. We have home care marketing in April and clinical coordination with secure messaging in May. So watch your email. We'll have all of this information available for you and a chance to check out our partner SHP and a chance to check out Devero if you like as well. So Chris, Zeb, thank you so much. Very useful, and would like to thank everyone for joining us today as well. Watch later today for the follow-up email, and have a great day.